I'm going to hand you over to Kumar Murthy, who is going to introduce our speaker today.
Thanks, Sarah. Thanks, everyone. Welcome to the seminar. Good to see you back here. We're very happy today to have Professor Ji Huo from the University of Miami. She was actually a postdoc in Toronto, working under Jianhong of York. And she's well known for her work on blood transfusion therapy for Ebola patients. And she's been working very hard on this kind of research in the context of COVID-19. So we're very honored to have her here and looking forward to her talk. Xi, please.
Thank you, Kumar, for the nice introduction, and thanks Jianhong and Kumar for the kind invitation. So it's happy to speak here, and I'm happy to see so many names in the participating list. Thank you guys for coming. So can you, it's okay for you guys to see my screen over here, right?
Yes, we're able to see it.
Okay, cool. Thanks. So today I'm going to talk about the use of large-scale use of convalescent plasma and the potential for this treatment method for the severe COVID-19 patients. So this is a joint work with Xiaodan Sun from Xi'an Jiaotong University, with Nicola and Jianhong from York University. So actually to us, it's not a new model. So we have been looking into that ever since the Ebola outbreak. And we think it's very worthwhile for us to apply it to the current COVID-19 pandemic. And I will explain more. So, okay. So the first of all, let me talk about something about this kind of treatment. Which is called the convalescent plasma transfusion. So
we are still in the first page, just in case.
Oh, really? Let me see. Can you see my screen now?
It's on the first page, title page.
It's still on the first page.
You might want to just simply maybe exit and then do that again.
Will do. Let me see. So you don't see my mouse or anything like at all?
No, we just see the first page.
Right. Let's see page.
Does that mean you need to be given the co-host the status, or?
Can you see it now? I'm scrolling.
No, we
no.
Will be sufficient.
I start from convalescent plasma transfusion. So what does that mean is the convalescent plasma you take from people who recently recovered from COVID-19, for example. So, and then what do you mean by that is like everybody knows that there's a significant percentage of people that they would contract COVID-19, but they can recover just by themselves. So many of them are just having mild symptoms. And then like it is believed that for people who can fight against the virus by themselves, they're just fighting against the virus by using their immune systems. And then in this way, after their recovery, there are certain kind of antibodies against this virus that are residing in their blood. So, so the idea is, why don't we just collect the blood from those convalescent patients, and then and the actual process is like there's a blood collection from the convalescent patients, and then they usually use a medical equipment called apheresis, and then they run the blood from the apheresis, and they only keep the plasma part of the blood, and the rest of the blood is getting returned to the convalescent patients. And then once you get the plasma collection, there should be a certain amount of antibodies in it, and then we can make use of this kind of antibody and transfuse that into those who are critical ill. And then those antibodies from the survivors are believed to be able to help those current ill patients to fight against the virus in their body as well. So that is why it's like you're making use of somebody else's antibody to fight against the virus for those ones who cannot generate the antibodies really well inside their body. So that is why this type of treatment is also called the passive immunotherapy. So you're just borrowing the antibodies from the survivors. And then, so this picture is really nice, and I'm taking this picture from a convalescent plasma and COVID-19 from a JAMA paper, which has published recently. So, sorry, have to scroll down, sorry guys. So then before we go ahead and talk about the model, let me talk about more about the background. So first of all, I don't think I need to stress anything about the current pandemic. Everybody is being affected more or less, and everybody knows that it's not lethal to everyone. So there's a certain percentage of patients who can recover just by themselves. There is also a certain percentage of patients who would develop really severe symptoms. And then some of them even go to more critical symptoms. And then there's an early study in China published in JAMA saying that for those people who are critically ill, they will have the fatality rate for those COVID patients who are critically ill are about like up to 50%. So maybe a half of the critical ills would die from the disease. So there's still, like, even though it's not a serious disease for everybody, but for those who are critically ill or have pre-medical conditions, then the death rate is really high. And then another thing is since COVID-19 is an emerging disease, so there's no time for us to develop any drug or to develop any safe treatment efforts that are medically proved to be promising to treat patients. So currently there's no treatments that are available for COVID-19. That's the problem, and that's not only the problem for COVID-19, that's also a huge problem for other emerging epidemic diseases. So so that is why we think the doctors think human convalescent serum is going to be an option. So for several reasons. So the first reason for people to consider making use of this treatment is that the resource is rapidly available. So because remember, you take the convalescent plasma from the recovers. So as long as you have a certain number of patients that would be able to fight against the virus by themselves, you have a certain number of survivors, you would have the resource to acquire this kind of treatment. And another reason is it's proven to be at least safe. So so this is actually a much newer study which has just published by Mayo Clinic Proceedings in July, and this study is about making use of the convalescent plasma for 20,000 hospitalized patients, and the method is shown that even though they cannot estimate the efficacy of this treatment yet, but at least they can show that it is a safe treatment. So it's not going to bring extra harms to those critically ill patients. So, and the third reason for considering this is it's not a new idea. So it's really a strong, idea which has already had a lot of historical successful record. So so this is the passive immunotherapy has already been thought of, or actually even have been implemented almost more than 100 years ago during the 1918 H1N1 influenza pandemic. And also more recently, it has been recommended as one of the treatment strategies For example, in the recent H1N1 outbreak, and as I mentioned before, is for example in the West Africa Ebola outbreak as well. And for coronavirus, we have the SARS-1 outbreak and MERS in 2012. And then during both of the outbreaks, the convalescent plasma transfusion has been recommended by as a potential strategy. So it's not new. It has a strong historical record. But before I talk about the unknowns, I want to mention that during the 2014 Ebola outbreak, it was the first time that the World Health Organization has issued an interim guidance about making use of this convalescent plasma transfusion as a large-scale treatment method. So, in terms of the large-scale treatment method, you need to involve as many as possible survivors from the disease, ask them to make donations, and then you have to process all the donations. You have to consider what are the best methods for you to store them, and then you have to do a dissemination of this kind of blood products and to treat ills. So that gives us so many unknowns. You never know how this large-scale use of convalescent plasma would work, and what we can do to make it work better. So, for example, you don't know for COVID-19 at least. You never know about the treatment efficacy. You don't know how much of the fatality ratio would be altered by using this kind of treatment. And also, you never know that if you're having so many survivors and you're having so many ills, then how are we going to manage that logistically? And also, how are we going to store the blood products, and how are we going to decide which one of the patients should be able to get this kind of treatment? So, so that's why we think it's actually a mathematical problem based on the population dynamics. So, and the population dynamics originated from the transmission of the disease for sure. And then once you have those infectious individuals, they are isolated. Some of them would need treatment. And then for those who survived, you will have a number of recovered individuals. And then you can ask them to make blood donations. And then once you have amount of potential donors, you have to arrange the whole collection dynamics for the blood donations. And then after you collect all the plasmas, you have to consider how to storage them. And then how do you manage the number of your stockpiles, and how are you going to deploy the stockpiled blood products to treat those patients in turn. So we think that this is a huge, complicated system for population dynamics, and we would like to model it by using differential equations. So, but as I said, there are less things that we know about it, because even though the FDA in America, in the United States, have already issued this as an investigational treatment that are valuable for doctors and for patients to try. But there are still certain kind of details, for example, parameters that we really don't know about it. So the best information, or the detailed information we get about this whole process, actually comes from the 2014 West Africa Ebola outbreak. So that is the WHO interim guidance that I was talking about at the beginning of the talk. So so in this guidance, it actually illustrates all kind of details that you may want to know in terms of how do you do collections of donations, and how do you manage donors, how do you storage your blood products, and things like that. So so for those of you who are interested in, we actually there are two of our works related with the large-scale use of Ebola, large-scale use of the convalescent plasma for Ebola outbreak in 2016. So we did one simulation work, and also we did another mathematical analysis about this kind of system. So, but I want to say that for COVID-19, it's no longer same problem, because there's the huge difference between patients with COVID-19 and patients with Ebola is that Ebola really has a really high mortality rate for everybody. So everybody who contracted with the Ebola virus are in a critical condition, and the death rate, mortality rate of the Ebola virus is as high as 70%. So, but for COVID-19, things are totally different. So you will have a lot more survivors, and relatively you will have a smaller portion of people who really need this kind of passive immunotherapy. So that is why we think the way that you're going to model it is going to be totally different. So that's why you will have totally different ideas about the effectiveness and feasibility of this kind of method. So that is why we get started with our work. So for more information about how to make donations and how to screen for donors, you can find it from the American Red Cross Blood Services website. So I don't know, for those of you who are currently in the United States, if you're watching YouTube in the States, you will see that there are certain advertisements from the American Red Cross Blood Service or from the Mayo Clinic that would ask you to consider donating your blood if you're a current survivor of the COVID-19. And there are, like, the criteria for qualified donors are not strict. So as you can see, you have to be an adult and you have to have a reasonable weight, and then you need to be in good health, and then you're sure that you were prior exposed to the disease and you have a verified diagnosis of COVID-19. And then you may be considered for a donor of your plasma. So then I think that's enough with the background, and then I'm jumping into the model. And so there are so many regions that are getting affected and still being affected by this COVID-19 disease. So, but we conduct this study in late March and in early April. So during that time, Italy was hugely affected by COVID-19. And then we chose Italy as a good example for us to do this kind of simulation, as making use of the large scale of convalescent plasma to treat those critical ill patients. And then another reason for us to choose Italy is a developed country, and then it has good medical system. So we want to see that whether or not it's feasible for developed countries to consider using this method. And another reason is, of course, one of our collaborators, Nicola, is Italian, and moreover, Italy does have much more multi-dimensional and detailed outbreak data available online. So we think it's easier for us to calibrate some of our transmission rate parameters. So. So as I said before, to consider this problem, everything should be originated from the transmission dynamics of the disease. So that's why I split our model into two different parts, but they're interconnected with and have overlapping compartments. But I'm just talking about the transmission dynamics for simple as the first as the beginning part of our model. So. Since our goal is to simulate the use of convalescent plasma transfusion, so we develop a really simple transmission dynamics model to describe the transmission of the virus. So of course, we consider an SEI model over here, and everything's traditional SEI model. And then for those kind of patients, we categorize patients in terms of their severity of the disease. So you may have patients who just need palliative care, or who can just take care of themselves by isolating at home. So you may have patients who are having mild to severe symptoms. And then you might have patients who are in critical condition. Those are the ones that we are talking about. Those are the ones staying in the ICUs. And then each type of the patient will have a linear rate to recover or to die. So, so the way that we are modeling those kind of patient dynamics is we consider for all the infectious populations, once they are isolated, they always start with mild to severe symptoms. And we assume there's a linear rate for those patients, for some of the patients to develop even more critical conditions, and they become those critically ill patients, and they stay in the ICU. And then we assume linear recovery and death rates for sure. And based on the literatures, we assume that for those patients that are in mild to severe condition, they actually, there's a 0 death rate for those kind of patients. But for those patients who are in critical condition, they can either recover or death at different rates. So as you can see in the table over here, we present the transmission parameters that we use in this model, and some of them are calibrated from the real data in Italy. So we try to fix as many of the parameters that we know from literatures. And then we figure out that we still need to calibrate at least 4 different parameter values from here, but also I will talk about that in the next slides, and you will see that we also need to estimate the initial number of populations in different compartments as well. So, so the 4 parameters that we are calibrating over here, 2 of them comes from the transmission rate. So we assume that Italy tries to control, of course, Italy is doing very good in controlling the spread of the epidemic by using the non-pharmaceutical intervention strategies. And then since our goal is not to make predictions over here, so so we assume for as simple as possible that the transmission rate will decay exponentially as the non-pharmaceutical intervention strategies are enforced over time. So, but the rate for that exponential decay is not known. So that's one parameter we try to fit. And the basic rate of the transmission rate, which is usually the beta value that we use for most of the SEI models, is unknown. So the one colored in blue is also being fitted. And another thing that we are not sure is this rate, the progression rate for people to develop critical conditions. So so this is another rate that we choose to fit. And for the recovery rate for the mild and critical cases, we try our best to get them from the literature. And but since the death rate is one critical thing that also matters, the output of our model as well. So we fit the death rate of the critical case as well to the data. And as I mentioned before, from the literature, for those people who are in the mild to severe compartment, we assume that there's no death for people who are outside of the critical condition compartment. So, so this is about the transmission dynamics. And before I jumped into the blood transfusion part, I need to convince you guys that we try our best to fit our model to data first, and then the transmission dynamics is complete. So, so we did a really simple data fitting. So we used the whole Italian data, and then we start from February 23rd, which is not the starting time of the transmission, of course. So that's why we need to fit some initial conditions as well. So, and we make use of data for more than 30 days. And then we didn't do any other fancy data fitting skills. We just did a least square fitting. And as I said, the good point about Italian data is they do have a multi-dimensional data set. So what we are doing is like in the least square fitting, we are trying to minimize this error in between data and model predictions. So one part is about the cumulative number of reported cases every day. And this part is about the cumulative number of death cases every day. And the third part is the cumulative number, the third part is the current daily population or daily number of patients in ICU. So, so as you can see, we have the ICU data, so that's why we can estimate the progression rate from mild to critical. So, so altogether, together with the prior 4 unknown model parameters that I mentioned in the last slides, as I said, we are starting our simulation in the middle of the outbreak. So, so we don't know at the very beginning on February 23rd, how many people are actually in latent period or how many people are in the infectious yet not isolated period. So, so we have 2 extra unknown contents to fit as well. So there's a total of 6 unknowns to fit to this kind of data. And then there of course are some identifiabilities of the fitting. So in order to overcome that, we try to fix this decay rate of transmission at different reasonable levels. So there are more than 6 scenarios that we've tried, but I select 6 of them to present over here. So, so we fixed that decay rate of transmission from the level of 0.2 up to the level of 0.7. And after we fix this value, we fit the data and to estimate the other 5 parameters based on the multidimensional data. So, after a while, and we compare all the fitting scenarios, and then we pick the best fitting result as the one with the transmission decay rate to be 0.05. And then we present our fitting result over here in those 4 pictures. As you can see, the right one on the top is the cumulative confirmed cases, which is the CI, the one that we are fitting. And then we also fit the cumulative death. And then we fit the daily number of cases in the ICU. We also plot the daily confirmed cases to validate our fitting. And we can see that by fitting those, the other 3-dimensional data, and the fitting goes well as well. So again, so since our major goal of this study is not to do the data fitting or the prediction. So, but I still want to talk about is like the fitting is at least reasonable in the scale of the actual data. So, so I got the data from as of yesterday about Italy, and you can see that the total number of confirmed cases are almost of the same scale with the one that we estimated in our fitting more than 3 months after February 23rd. And also we might have overestimated the number of deaths. So let's keep in mind, we might have overestimated the fatality rate of the critical cases. So, but anyway, we use this this data fitting results to continue and study the convalescent blood transfusion. So, so here's the other part of the model, and which is the one talks about transfusion dynamics. And as I said, because like the whole model is a really long one, and this is the second part of it, and And it gets overlapped with the first part about the patient categories as well. So you will see that from the transmission dynamics, you will have a rate of infectious population coming in to the mild to severe symptom patient category. And here's a title, it should be P instead of Q. But there's a progression rate of disease for those who are in mild condition into the critical condition, of course. So those are the two compartments that you've seen in our transmission dynamics. And the other compartments are actually related to the convalescent plasma transfusion. So here you can see for those people who are in mild conditions, they will recover and in the recovered class. And then now let's think about how do you deploy this convalescent blood transfusion. And then you should be able to have a certain amount of people who are in critical condition to be treated with the convalescent plasma, right? So I denote that for CP for short. So there are some people who are receiving this transfusion therapy. And also, it really depends on how many blood products you have, how many convalescent blood products you have. So maybe not all of them are going to receive this therapy. So some of them might just survive under palliative care. And they can recover as well. And then also there's a death rate for those people who are in critical condition without using the blood transfusion treatment. And for those people who are currently treated with the convalescent plasma, there's a linear rate for them to recover. And also there's a linear death rate for them as well, because we really don't know the effectiveness of the convalescent plasma therapy. So, so this is the whole part about the treatment strategy, the treatment dynamics. And now for those who are recovered, some of them are qualified for making donations. So here we move to the donation dynamics. So we assume only a proportion of them are qualified to make donations. So only a epsilon amount of them are going to become first-time donors. So if they are in first-time donor class, they would be able to make a donation on at a linear rate. So we assume that if they make a donation today, then we will move this kind of donors to the rest stage over here. So those are the donors who have already completed at least one-time donation, and they have to rest for a certain number of days to consider making a donation again, or they can quit as well. So so this process is described clearly in the WHO interim guidance, and the interim guidance actually suggests that those donors should wait at least 14 days until to be considered for the next time donation. So that's why, as you can see, we're modeling this whole process by using a delay term. So so after exactly 14 days, so those donors at rest would be able to consider as a multi-time donor for sure. And they can also, the multi-time donors can make a donation and they go back to the rest stage again. So, and also we assume that the first-time donors and multi-time donors make donations at a linear rate, alpha, with the parameter alpha every day. And also for all types of donors, no matter whether or not they are active or at rest, there's a linear loss rate of the donors every day. So there's a possibility for donors to quit becoming a donor anytime. So as you can see, for all those solid lines and the blue compartments, they're all related to the population dynamics. So there's a population dynamics of the treatment strategy, and there's a population dynamics of the donation strategy. But other than the population dynamics, there's blood transfusion, blood product dynamics. So here comes from the donors. So once the donors are making donations, their convalescent plasma are collected. So here's the collection strategy. So are collected and stored in a blood bank. So that's why we color it in red, and we make use of all the arrows in terms of the dashed lines, because we want to indicate those are not population dynamics, but they are blood product dynamics. So once you collect all the bloods, you store them in the blood bank, and then there's a chance for you to make use of this blood and involve with the treatment strategy over here. And of course, according to the WHO guideline, there's a certain rate for the blood product to expire. So if you have too many of them that are not used, so there's a linear expiration rate for the blood products as well. So as you can see, the whole equation about the blood transfusion dynamics is listed over here, and we make use of delay terms as well. And another thing I want to mention about is how you are disseminating this blood product to treat patients. So this is the term of the rate of treatment for critical ill patients to receive blood transfusion therapy. So this rate is really depending on how fast the eta parameter, how fast you are deploying the blood product to the hospital, and also is proportional to the number of people who needs this kind of treatment, so proportional to the number of critical ill patients. And also another factor is really depends on how are we going to make use of the blood bank storage. So here we introduce one parameter K. So this is a saturation function, and we introduce this parameter K to reflect the burden of deployment of the blood bank. So the higher K value is, the more conservative you're making use of the blood products in the bank. So so this is the key part about the transfusion dynamics, and then we are almost ready for our results. So so since I said there are so many unknown parameters, and we are doing this simulation just to talk about the potential use of this large-scale convalescent blood transfusion treatment strategy. So we have to make a lot of assumptions on the unknown parameters for sure. So some of them are available from the WHO interim guidance about Ebola, but some of them are really depends on the local population. So for example, the most important one is the K value, which the deployment burden, as I said, whether or not you're using the blood bank storage really aggressively or conservatively. So we have to check the sensitivity of the whole system with respect to different values of this burden, for sure. And another thing is like, we really don't know how the effectiveness of this convalescent plasma transfusion. So we just know the fatality ratio for the critical cases of COVID-19 is about 50%. So what is the fatality ratio of the critical cases under this treatment? Is still an unknown parameter, so we vary that in really wide ranges. Of course, it's reasonable for us to just consider it varying in between 0 to 50%. So if it's higher than 50%, then there's really no need for us to consider using this treatment. So also we don't know about the probability for people to be qualified for donors, and that's an unknown parameter. And also we don't know what is the daily rate for donors to make donations. And also we don't know what is the loss rate of donors on every day. So those are the unknown parameters. And also there's another one parameter that we think might be very important, is like based on the situation of Italy in late March. So what is the best timing for you to implement this population-wide strategy? Of course, this is a simulation study, and of course, everybody would think that we should, if this treatment is actually effective, you should start that as early as possible. But the side effect is like if you're starting it as early as possible, there might be a higher demand of the apheresis equipment, or there might be a higher demand of the donor screening and everything over there. So would that be feasible as well? So that's another thing that we have in mind. So so the first thing that we do to present our results is that we summarize what kind of outcomes that we are really interested in. So first of all, we're really interested in the treatment burden. So we want to know that as time goes by, how many patients are really in the hospitals are going to have this treatment strategy, and whether or not you will have enough healthcare workers to actually perform this kind of treatment strategy. And the second thing that we think is important is we really want to know that what is the daily rate of collection of the convalescent plasma. So it really depends on how many people are donating every single day. And also the donor screening is another big issue, because it's not, to be qualified for donors, you have to screen this survivor for multiple different kind of diseases, and also other unknown factors that we mathematicians cannot perceive. So donor screening would be another portion that requires a lot of labor. So we really want to know that on average, how many patients how many survivors need to be screened every day. So that really depends on, that really comes from the flow from the R class to the D1 class. And so that's about the collection and screening. And also we really want to monitor the blood bank product stockpile every day. Right? So we really want to see whether or not we have enough left for emergency issues. And another thing we want to know is overall how many lives can be saved. Of course, that's one important factor. And also, we want to know what is the peak time demand of the apheresis. So apheresis, remember, that's the medical equipment required to perform this kind of transfusion. So we really want to know like how many procedures we need to proceed every single day just to using the apheresis equipment. So those are the several aspects that we think are very important to simulate, and we want to see how they would change with respect to different modeling parameters. So so of course we try to see that if we are varying K, what kind of things are going to change. For example, remember the higher K values really represents the more conservative use of the blood bank storage. And you can see that actually it's not actually going to affect the donation strategy, no matter what kind of K value you choose. But whether or not you're using aggressively or conservatively about your current blood bank storage really would impact how many people can receive this kind of therapy and how many blood you are left in the bank. So that's a reasonable result. And then the next thing we do is we try to see how the loss rate of donors would impact the whole thing. So of course you can see that if more donors are lost, you will have less daily donations, you will have less people receiving this therapy, and then you will have less blood bank level. And the same thing oppositely happens for the daily donation possibilities as well. So everything is expected intuitively as well. And the other thing that I said, like, is the timing for you to implement this large-scale transfusion therapy nationally. So, so since we fit the data up to March the 30th, so we assume that you can either start this population-wide CP therapy from March 31st, or 2 weeks later, or 4 weeks later. And then you can see that the daily donations are actually boosted if you're starting this whole thing as late as possible, because you will be accumulated with a lot of potential donors if you start late. And then, of course, the number of patients can be treated would be totally different. And also, we do this wide range sensitivity analysis for the ratios of qualified donors. And as you can see, if based on the population, if you have more qualified donors, then everything, the situation will be better. But the daily donor screening would not change for sure, because so those are just the recoveries. So you have a certain number of recovered individuals, and you need to screen. So the daily donor screening is not that bad. It's not that affected by the ratio of qualified donors. And then remember I said that there are two more things that we really want to know finally. So we want to know how many deaths can be avoided. And then we want to know what is the peak time demand of the pheresis equipment. So then we do this kind of sensitivity analysis based on the wide range variation of the four significant parameters, and everything is expected as we think before. But you can see for different parameters, if you vary it from the lowest bound to the upper bound, you can see that the number of lives can be saved would be really ranging hugely. So the number of lives can be saved can range from more than 1,000 up to 10,000. So and another thing that we can do is as again, we don't know the effectiveness of this kind of therapy. So we have to vary the potential case fatality ratio under this kind of therapy from 0 to 50% as comparing to the fatality rate for critical cases. And also we have to vary the timing for us to implement this therapy after March 31st. And then we measure this by using a heat map. By evaluating the number of deaths can be reduced. So as here you can see that the number of deaths can be reduced really depends on how effective the convalescent plasma transfusion therapy is. So if it's as effectiveness, if it's not that effectiveness, if the death rate is the same with the natural death rate under palliative care, then it's really not necessary for you to implement it at any time. But if the death rate is really promising, and it would be definitely better for us to implement it as early as possible during the middle of the epidemic. So, so the last thing that we did is remember that in the data fitting, we assume different transmission reduction rates of this whole strategy. As I said, the outcome of the transfusion strategy really depends heavily on how you're actually going to control this the spread of the disease. So if the non-pharmaceutical interventions are performing well, then you will have less cases, you will have less number of expected deaths. Then this how does this CP therapy would require, or how many deaths can be avoided by using the CP therapy. And here's how we did it. So so in each barcode over here, we fix the reduction rate of the transmission over here, and then fit the real data with the model. And then we do this kind of simulation strategy to see how many deaths can be avoided under different scales of non-pharmaceutical interventions. And as you can see that if for larger R values, that really represents more significant non-pharmaceutical interventions. So if you're controlling the transmission a lot more better, then you will have to, then the CP therapy, you will have less cases coming on. So you will have less deaths as expected. So once you're using the CP therapy, you will have, this therapy will save in terms of number of deaths, but it's still going to save a considerably amount of deaths over here, as much as more than 10,000 for sure. And then of course, if you have less transmission, you will have less survivors and you will need less donations. So the peak time of viruses demand will be reduced for sure. So you will have less burden of doing the collection and screening and everything about this convalescent plasma. And then based on this figure, we can talk about something a little bit realistic for Italy. For example, based on this figure, based on the weakest non-pharmaceutical intervention over here, you will need the maximal daily demand of the viruses as 934 per day. So you will have to process more than 900 cases of donations every day by using the viruses. And we actually find that there are in total 61 apheresis centers in Italy. So what does that mean is that at the peak time, the apheresis processions are needed for each center for every day is only 15 processions per day. So which we think might be pretty much feasible given the current apheresis centers in Italy. So so that is basically our conclusion is, of course, the transmission control is the key, because that really tells you how many people are infected, how many people needs to be saved, how many donors you're going to have for sure. But overall, no matter how the transmission intervention goes, or the transmission, no matter how the transmission control goes, this convalescent plasma therapy will always be able to save a considerable amount of lives for sure, provided we assume that the effectiveness of the blood transfusion is actually working for everyone. And also for developed countries like Italy, is totally manageable, no matter when you decided to start by using this kind of therapy on the population level. So so this is what I want to say about that. And then here are some acknowledgements, and all of our authors are partially supported by different grants. And also we actually initiate applying our model to COVID-19 as early as in February, I think. So so the first application we did is just we try to discuss the potential feasibility of using that in one province, Hubei in China, which is the province as the epicenter of COVID-19 in the early time of this year. So we first wrote this paper in Chinese with Xiaodan soon, and it has published at the very beginning, and then based on our experience of the first model, we can continue our study for the Italy as an example over here. So I think that's all I want to say. So and I'm happy to take any questions.
Thank you very much, and Xi and Sarah or Phil seems to remind we'll open the channel for questions, but I would like to make a comment first of all that this province, and I'm sure many other regions and countries have been considering building a larger facility to produce the blood the product and antibody treatment, develop antibody treatment products. And during the period of after the Ebola outbreak, and unfortunately, this is always the case. All this larger public health facility that need to be built to prepare for an outbreak has always become a low priority when the pandemic is gone. And I think this research really shows the feasibility of implementing this. But one of the projects that we have been involved is trying to really build international collaboration, because you need to collect the blood donation globally in order to really build the bank for both production and for research. And again, I hope WHO is continuing its effort to really to build in this capacity. So with that, any questions from the audience?
I have questions.
Yes, Matthew.
So thank you very much for a very nice talk, first of all. And then second, my activities on translation medicine in Emil von Behring Clinic in Berlin show that usually this is some kind of administrated for treatment is much important than the treatment of disease. So the administrative is very important. Therefore, the first question is, maybe it will be reasonable, really it will be reasonable to prioritize the persons or the patients, the optimal list. So maybe it will be the reasonable for clinical efficiency.
Yes, so I think, yeah, so that's what we can continue working on for this model. For example, there are some literature showing that it's more effective if you do this blood transfusion for patients who develop critical symptoms within their 14 days of symptom onset. So it really depends. So the effectiveness of the therapy would also depends on one so it would really depends on the infection age of this person. So it depends really on what is the best timing for each individual for you to give this therapy to. So of course, it's another potential direction for us to better improve this model. For example, you can incorporate the age structure, infection age structure for patients. And then, and I guess, and you can do control studies, and then I guess that's a better way for us to decide. For us to decide a reasonable queue of patients to actually receive this kind of therapy, especially when you don't have enough blood stockpiles available. Right? So
your equation show that you are dealing with homogeneous population. Am I right?
Yes. Yes.
And that means. That means if you are dealing with a homogeneous population, you at least you should your model should not take into account the randomized clinical trials.
Right. We are not taking in consideration of that.
And
so
then,
right.
Yes. The last question, this is for me, this is a little bit intuitive. You say that you don't have, at least if I correctly understood, any side effects. But actually, if you are dealing with the real things, then if you just adding more liquid volume, more liquid volume into a person's vascular system, it could lead overload. Because if in your picture you also show that how you are dealing with this system, the transfusion, right? So that they are putting to the some liquid to the person in order to control blood dynamics, and then it lead overload. So why it's not will have any side effect?
You mean the side effect of not having enough blood for everybody, or? Okay, so yes, so we are, based on our simulation and based on the data in Italy, what we have over here is, as I said in the equation, so we use a saturation term to describe how we are going to allocate the blood. So over here, so here's the treatment rate of patients that can receive this kind of blood transfusion therapy.
Mhm.
And here, this rate is proportional to the number of patients who are in need of this therapy for sure. And also this rate is also dependent on the blood bank storage. So, so if you have, so we just, for simplicity here, we just use a very simple saturation function over here. So that means if you have more stockpile, then you will have more requirement to be filled. And then, as you said, a more realistic way of modeling this would be by using a stepwise function here. So,
Yeah.
so you can just first try to see how many you have currently in the bank, and then just allocate a certain amount of the blood over here. So, so I think that's more realistic when, especially, you don't have so many blood in the stockpile. But over here in our model, so everything turns out to be reasonable. It's just, I think the major reason is because it's Italian data, and we assume that the transmission is under control after, it's not going to blow up for sure. And another reason is like it's COVID-19. So so you still expect a large amount of people who can recover naturally and become donors. So you always have a larger proportion of people who can donate their bloods and store those stockpiles in the bank, and you will have less proportion of people who are in need of this treatment therapy.
Thanks a lot.
Thank you.
No, I have another comment. Is right now when talking about reopening or smart reopening and going back to normal, then one of the issue is really let the young people go back to work and to school first. And I think that might make the blood transfusion, if turns out to be necessary, I hope it's not, more feasible, because in the outbreak, the incidence, the epidemic is going to propagate from the younger age to more senior and immune-compromised age groups, and by the time reach the second wave, then maybe the relatively young group can donate the blood, and so that this kind of age specify specific waves and may provide an opportunity for this kind of treatment. And
right.
So,
right. So I guess for COVID-19 is still a promising way to use the blood transfusions. So it's like, as we you will have, like under the current situation, you might have more people who are infected that are really young, and they have a really high chance of becoming survivors. Right.
So, but I think there are also antibody drugs, treatment drugs, rather than the fresh blood transfusion. Maybe that could be an alternative. Again, that would be the same similar model framework applied, but in different setting.
Yes, of course. So in here we assume that one donation would be able to become one storage in the bank, and then you might use one storage in the bank to treat one patient. So here the ratio is between donor and treated patient is 1:1 for sure. So in our model we assume that's 1:1, and yeah, I've seen that there are other studies investigating whether or not you can make use of the antibodies collected from all different patients, and just develop new treatment strategies for sure. And then in that way, maybe it's no longer 1:1, it's 1:100. And you never know. So I'm not a medical expert, and I think like here we are just assuming the ratio to be 1:1. But initially I think that we are assuming this because the purpose for us to initially for us to develop this model is like this is almost the only strategy for us to treat people once you have an emerging epidemic disease and once you really don't have any time to develop new drugs or you really don't have any time to develop other kind of treatment methods. So this is almost the worst case scenario, I guess.
Okay, any other questions? So a number of questions about whether we can share the slides and the paper. So the early version of the paper is posted online. The first paper on the COVID in Chinese is hard copy, and you can write to Professor Hu or Professor Song for a hard PDF file, and the talk is videotaped, so you can play this anytime. So with that, I want to again, on behalf of the Fields Institute and on behalf of this task force, I want to thank you, Xi, for your very interesting talk, and we wish you all good luck and good health.
One the historical fact I would like to say, as I said, I am working with Emil von Behring Clinic in Berlin.
Okay.
And then Emil von Behring was a founder on convalescent plasma. And for this, he received Nobel Prize.
Ah.
But this is
so maybe you can share this
yes,
slide,
yes,
of
course.
I think we need to push several. I know a few foundations are interested during the Ebola situation, and
so this is a very interesting fact that when I started work with them for completely other things, for lung cancer, I worked, but I realized that he was the founder for this. He received Nobel Prize, and today it was very nice talk. Remind me how it was the Emil von Behring's, the founder, was very useful. Thanks a lot again.
Thank you so much. And thank you again for everybody coming. And I can't help notice a lot of familiar names from the panel. Thank you so much for your support.
Thank you very much again.
Bye. Thank you. Bye.
Just good.